Next, we have three more presentations on this session. All three are from radiation oncology. I invite Dr. Reenu Madan, additional professor of radiation oncology from PGH Chandigarh, to present on phase 3 trial of SBRT in localized prostate cancer. Welcome, doctor.
Good morning, everyone, and thank you organizers for having me here. So I will present phase 3 trial of stereotactic body radiotherapy in localized prostate cancer. This was published in NEJM October 2024. So prostate cancer is a global health challenge, and low and intermediate risk prostate cancer patients, they constitute a major proportion of all diagnosed prostate cancer patients. So the curative option for these patients include active surveillance or surgery or radiation therapy. And as we know, the alpha-beta ratio for prostate cancer is low, so hypofractionated radiotherapy offers a radiobiological advantage for these patients. So what is SBRT? It's an extreme form of hypofractionation, also known as ultra hypofractionation, when the entire radiotherapy dose is delivered in 5 to 7 fractionation. PACE trials actually, they evaluate the role of SBRT in localized prostate cancer, and PACE-B trial compares SBRT versus radiotherapy in low and intermediate risk prostate cancer, not requiring ADT. So in this trial, PACE-B trial, this was a phase 3 international open label non-inferiority randomized control trial, which was conducted at 38 centers across UK, Ireland and Canada. And from 2012 to 18, 874 patients were included in the trial and were randomized to SBRT versus control radiotherapy, which was either conventional radiotherapy or hypofractionated radiotherapy. So these are the inclusion criteria. Patients more than 18 years of age, histologically confirmed prostate cancer patient with good performance status, life expectancy more than 5 years, low intermediate risk patients were included in the trial, and those with high risk cancer were excluded from the study. For radiotherapy planning, insertion of 3 or more fiducial prostatic markers were recommended. Moderate bladder filling and bowel preparation was advised. An MRI before radiotherapy was recommended, and CT-MRI fusion was performed with fiducial matching. Clinical target volume for low-risk prostate cancer patients was only prostate, while for intermediate risk patient, proximal 1 centimeter of seminal vesicle was also included in the clinical target volume. PTV margin differed between the conventional radiotherapy and SBRT. For conventional radiotherapy, it was 5 to 9 millimeter all around, while posteriorly 3 to 7 millimeter, while for SBRT, 4 to 5 millimeter all around and posteriorly 3 millimeter. This was the radiotherapy dose. For SBRT, 36.25 gray in 5 fraction daily or alternate day was prescribed to the PTV. And for controlled radiotherapy, 78 gray in 39 fraction was prescribed 5 days a week. But after 2016, when the results of CHIP trial were published, 62 gray in 20 fractions was also permitted. The endpoint of the study were primary endpoint was freedom from biochemical or clinical failure, and secondary endpoints were commencement of ADT, diagnosis of metastatic disease, disease-free survival, overall survival, and all these outcomes were analyzed at 5 years after treatment. So after radiation therapy, patients were monitored with serial PSA every 3 monthly for 1 year and then annually thereafter. Physician assessed toxicity and patient-reported outcomes were assessed at baseline, every 3 monthly for 2 years, every 6 monthly from 2 to 5 years, and then annually thereafter for a maximum of 10 years. So this was a non-inferiority trial, and the sample size was calculated based on the assumption that 85% of the patients in the control group will be biochemically free from the disease at 5 years. A non-inferiority margin of 6% was taken at 5 years. Trial were designed at 80% power, 5% one-sided significance, and allowed for 10% patient dropout rate. Coming to the results, Patients were well balanced between the two arms with respect to age and risk categorization. Majority of the patients were intermediate risk category, 90% were intermediate risk. So coming to biochemical failure and overall survival, we can see that the two arms, two groups, SBRT and conventional radiotherapy, are overlapping, and 5-year incidence of freedom from biochemical or clinical failure was 95.8% in SBRT arm versus 94.6% in conventional arm, which was statistically not significant. Overall, 79 patients died, 46 in SBRT arm and 33 in controlled arm, 2 in each due to prostate cancer. And again, this was not statistically significant, so this was concluded that SBRT is non-inferior to controlled radiotherapy with the hazard ratio for biochemical failure 0.73, and a post hoc analysis for superiority was also performed, which was not significant. Coming to toxicity at 5 years, again, we can see that till 2 years, there was some increase in the toxicity in SBRT arm, but after 2 years, both the arms were overlapping and there was no statistical difference in the toxicity between the two arms. So we can see here, grade more than 2 genitourinary toxicity in SBRT arm was seen in 7% patient as compared to 5% in control arm, and grade 2 or more GI toxicity was seen in around 1% of the patient in both SBRT and control arm. Again, this was not statistically significant. Similarly, grade more than or 2 erectile dysfunction at 5 years was also not significant. For patient-reported outcome, EPIC 26 subdomain score was also not found significant between the two groups of the patients. So Phase B trial showed the non-inferiority of 5-fraction SBRT compared to moderately fractionated radiotherapy with incidence of freedom from biochemical failure 95 to 96%, which was exceeded the expectation of the trial design. So I'll skip the background and previously published literature. This is one meta-analysis on SBRT in prostate cancer, where around 6,000 patients from 38 trials were analyzed, which also showed that 5-year biochemical failure-free survival of around 95% in SBRT without significantly increasing the toxicity. So strength of the Phase B trial were large sample size. It was a multicentric trial where quality assured radiation therapy was delivered in a well-defined manner in a homogeneous population, but the limitation was only 5 years toxicity data, and there may be more toxicity if the patients are followed up even for a higher duration. So to conclude, SBRT is a robust and viable alternative to moderately fractionated radiotherapy for selected patients in low and intermediate risk category, offers equivalent efficacy with respect to shorter treatment time, patient convenience, and resource utilization, but may slightly increase the risk of acute GI or GU toxicity. However, late toxicities are not different between the two group of the patients. Thank you.